So I'm going to start by thanking everybody for joining us today to find out more about the results presented at this year's EAU on HIVEC in BCG unresponsive patients. My name is Sarah Bruce White, and I'll be hosting the webinar on behalf of Combat Medical. In a moment, I'm going to introduce you to Dr Shen Tan, who presented this abstract summarising the results of a multi-centre European registry. Jen's a specialty registrar in urology within the North London rotation and an honorary research associate at UCL. He's published more than 60 manuscripts and is a regular reviewer for peer-reviewed journals. Awarded many grants within urological research, his experience has been gained at many prestigious hospitals, including the Memorial Sloan Kettering Cancer Center in New York. To give you a very brief overview, HIVEC is used across many countries with a variety of protocols to treat a range of non-muscle invasive bladder cancer patient subsets. Data accepted at this year's EAU and AUA included HIVEC versus BCG in a preliminary high-risk trial and further trial results in 2 additional settings. So that was assessing HIVEC prior to TURBT as an alternative to immediately post-operative, and 3 in a neoadjuvant setting prior to TURBT versus normothermic adjuvant. So over 800 patients have been recruited already to HIVEC clinical trials. Over 50,000 treatments have been given to date, and there have been 5 publications and over 25 abstracts presented over the last 5 years. So we have in the meeting today urology professionals and our distributors from many different countries. So thank you very much everyone for joining us. I just wanted to confirm a few logistical things before we start. So most participants should have been muted on entry. If I could ask everybody to keep themselves on mute just to preserve the quality of the meeting. If I can ask everybody, there is a chat function along the bottom of the Zoom toolbar. When you have questions and they can be typed in at any time during the meeting, type them in there and then we will address them at the end. I will read those out and they will be answered. To preserve the bandwidth and the meeting quality, it's recommended that everyone please turn their videos off as well. And please note, we will be recording this and sharing this. So you may also want to just go to the speaker view in the top right corner, and then you will just be able to see the slides and Dr. Tan presenting. So hopefully that's okay and everybody can hear us properly. So that's it for me. Thank you everybody for listening, and I will hand over to Shen now. Thank you very, very much.
Great, thank you very much, Sarah and Combat, for organizing this and for the very nice introduction. So this represents our abstract that we presented at EAU this year virtually, and it's on intravesical chemohypothermia using the Combat system in patients with BCG unresponsive non-muscle invasive bladder cancer. And this represents a multi-center European registry from 15 different hospitals. So this is my conflict of interest slide. So the recommended treatment for BCG unresponsive non-muscle invasive bladder cancer represents radical cystectomy, although we are all aware that not everybody might be a candidate for radical cystectomy due to comorbidities or due to patient choice. And there is an increasing need for alternative treatment for this cohort of patients. And here we report oncological outcomes in patients with BCG unresponsive non-muscle invasive bladder cancer treated with adjuvant chemohypothermia using the Combat system. So there's several ways how hypothermia works when delivered intravesically. It works by increasing the cytotoxic ability of chemotherapy, by increasing the permeability to deliver drug across to the cancer cells. It denatures proteins, it releases hit shock proteins, and works by activating T cells as well. And all these have been proven in preclinical models, and all these would lead to cell necrosis as well as cell apoptosis. So this represents a multi-center European retrospective cohort of patients from 15 institutions where they were treated between 2011 to 2019. Chemohypothermia here was delivered using mitomycin at 43 degrees Celsius over an hour. And BCG unresponsive disease, this represents standardized definition used by the FDA, and that's what we adopted for patients in this group of patients. And the primary endpoint for this study was 24-month disease-free survival and progression-free survival. And for the patients with CIS disease, we also looked at 6 months complete response rate. So many of you might be familiar with the system already. So the combat system represents a conductive hypothermia system. It's essentially a 3-way catheter that delivers heated heated chemotherapy, where it's recirculated, and it uses an aluminium heat exchange to heat up the temperature of the drug to 43 degrees Celsius, and it recirculates the system over an hour. So in terms of our patient cohort, we had 135 patients with the median age about 70 years. As expected, most patients were male patients, and most patients had a smoking history. T1 disease accounted for 36% of the cohort, and CIS-only disease accounted for 25% of the cohort, with 12.6% of patients had concurrent CIS with papillary disease. Over about 60% of patients had grade 3 disease, and these patients had a median follow-up of about 14 months. So this represents the results. The table, the Kaplan-Meier curves on the left represents recurrent-free survival curves, and in terms of the right represents progression-free survival. If you look at 12 months follow-up, roughly depending on the type of disease, we stratified the disease here to papillary-only disease, as well as CIS plus minus papillary disease. And as expected, if you've got only papillary disease, this group of patients would do better compared to CIS plus minus papillary disease. And the results here at 24 months follow-up suggest that with papillary disease, recurrence-free survival is about 62%, and this falls to 36% for patients with CIS plus minus papillary disease. In terms of progression-free survival with 24-month follow-up, not many patients actually progress to muscle-invasive disease, suggesting that this is a pretty reasonable treatment option. So how does hyperconductive hypothermia compare with other treatment modalities? A lot of you might be aware that recently the Keynote 057 study, where they looked at Pembrolizumab single-arm study at 102 patients with a BCG unresponsive CIS plus minus papillary disease. This has recently been FDA approved and presented ASCO GU, as well as the main ASCO, with a complete response rate at 6 months of about 75% and a disease-free survival rate of 53%. Historically, Berubicin was approved in the past before, and this has not really been uptaken in most centers because of its pretty poor oncological outcomes. Also recently in 2020, this adenovirus recombinant vector, this represents intravesical treatment where they look at 103 BCG unresponsive CIS disease as well as some papillary disease with a 6-month complete response rate of between 53% to 73% and a 12-month disease-free survival of between 24 to 44%. And also on the far right, this represents, of course, the current study and previous studies that I've published in terms of using hypothermia treatment as well. So if you compare the combat treatment that we report today compared to the Pembrolizumab data, it's actually pretty similar-ish results in terms of 6 months complete response rate as well as 12-month disease-free survival rate if you compare CIS plus minus papillary disease. So in conclusion, our data would suggest that in patients with BCG unresponsive non-muscle invasive bladder cancer treated with conductive hypothermia, 24 months overall recurrence-free survival was about 54% with a progression-free survival of 92%. Chemohypothermia seems to be a valid treatment for this group of patients who are unsuitable and who are not keen for radical cystectomy. Of course, this represents retrospective data and prospective data as well as randomized studies will always be welcomed in terms of validating these results. So I also want to share with you some of the outcomes of recent and pending upcoming RCT outcomes using the combat system. So this was presented by Felix Guerrero's group based in Spain. So they randomized 50 patients who had BCG naive high-grade disease, papillary-only disease to combat as well as BCG. And what they showed was it was comparable oncological outcomes at 24 months. This was recently accepted at the AUA, and the full paper is currently being written up, from what I've been told. This understandably represents a small cohort of patients, 50 patients, and might not be adequately powered to look at any difference in terms of the two different treatment modalities. And there are also two upcoming studies, HIVEC-1 and HIVEC-2. So these represent randomized studies with well-designed studies with power calculations, and they're looking at intermediate risk disease, and patients were either treated with cold room temperature mitomycin, or 30 minutes of heated mitomycin, or 60 minutes of heated mitomycin. And results of these studies should be coming out anytime soon now. I know for HIVEC-2, the 24-month follow-up data was up to January or so, and the data is being cleaned at the moment. So these results are eagerly awaited. So thank you very much for your patience and your time, and I appreciate that lots of you might be watching from countries where it's actually quite late at night. Thank you.
Shen, thank you very, very much for that. That was great. That was incredibly interesting. So as I've explained at the beginning, and I know that a couple of people joined afterwards, so may not have known this. So there is a toolbar along the bottom of the Zoom bar. There's a chat function. If people could type their questions into the chat, and then I will read those out and we can address those, if that's okay. That would, whilst people are putting questions into the chat, there's one come up there. What treatment regime do you recommend, and how many treatments and at what intervals?
So currently, in terms of the data analysis for this study, what we define as treatment was, it varies actually. Some centers use 4 induction treatments, some use 6. Some use a maintenance regime, so it's all a slightly mixed bag in terms of when you pull together multi-center data. In the UK, a lot of the time, at least for HIVEC-2, what is recommended is 6 weekly induction treatment, like what you would do for room temperature mitomycin. Based on EAU guidelines, generally, if you were to use chemotherapy, it's recommended that if you were to use any maintenance, it's up to a year or so, and that's what I would advocate, because we don't have enough data to support maintenance, beyond that or so. But in the UK, at least for intermediate risk disease, most people would give at least 6 weekly induction treatment.
Perfect. Thank you very, very much. And thank you. A question's just come in about what's your opinion about patients who had BCG intolerance?
So I think the patients with BCG intolerance, their outcomes are actually much better compared to BCG unresponsive disease, because it's not like they had recurrence of disease following BCG treatment. So I think, if you were to look at patients with BCG intolerance, essentially you should compare the data using the HIVEC system with BCG naive group of patients. So I believe that this is a very good alternative treatment, especially for patients who can't tolerate BCG, using conductive hypothermia, and Felix's results suggest at least they are at least comparable, although it's a small randomized study.
Thank you, Shen. That's great. And can we ask a little bit about adverse events? So I'd like to firstly ask about data for adverse events for the HIVEC treatments, if we can.
So a couple of years ago, I presented at EAU. Essentially, what we did was we did an interim analysis of the HIVEC-1 and HIVEC-2 randomized trials. So this was before there was complete. This was before we achieved completion of recruitment. And what we did was we showed, when we compared 60 minutes of hypothermia versus cold mitomycin, there wasn't actually a significant difference in terms of adverse events rate. Yeah, we did notice a few more hematuria and some lower urinary tract symptoms, but by far and large, they were pretty much comparable.
Fantastic. So, and just while we're on the subject of adverse events, I know that you had a comparison table a couple of slides back, if you're can scroll back to those. In terms of, and I know these are not studies you've conducted, but they've been covered in this year's EAU and so forth. Again, regards uptake of some of these other drugs and adverse events, how do you think HIVEC compares?
I think the good thing with the HIVEC treatment is it's a localized treatment delivered to the bladder itself, so you don't really get systemic side effects in terms of adverse events. So most of the adverse events from HIVEC is actually they're grade 1 or grade 2. It's quite rare that you get any grade 3 or above adverse events. And it's quite different compared to, for example, if you look at Pembro. Pembro is a systemic immunotherapy, and Pembro has a grade 3 and above adverse events rate of above 15%. So in terms of, and some of these adverse events actually can be lifelong adverse events. For example, if you've got endocrine related adverse events like hypothyroidism, these are, or developed diabetes, these are lifelong diseases that patients would have to suffer from. So it's worth bearing in mind that systemic treatments have other systemic adverse events, and it can lead to long-term consequences.
Perfect. Thank you very, very much for that. So next question. Thank you everybody for submitting these, because there's a range of questions coming through. So which follow-up do you recommend in terms of biopsies, cytoscopy, cytology, and what sort of follow-up schedule? And again, I do realise that you've collated these results and you can't represent everybody here. So it would be just good to get your opinion.
So in patients with BCG unresponsive disease, they all should be followed up as per high-risk protocol. So they should have a cystoscopy at 3 months or so, and it's worth remembering that when you look at CIS disease, in the BCG group of patients, you actually want to get a biopsy at 6 months to determine disease, because some patients might not have had a response at 3 months, but they might continue to have a response at 6 months. So I would mirror similar follow-up regimes, and so they should have 3 monthly follow-up for 2 years, and subsequently 6 monthly follow-up for the next 2 years, and then yearly follow-up, provided there's no recurrence of disease.
Perfect. Thank you very much. Hopefully that answers the question. So next question I'm just going to ask is, obviously this is a registry, so I'd like to ask sort of two things regards that, in terms of how important is registry data and what are the limitations, just so we're aware of those.
So registry data provides a snapshot of real world practice. So it's sometimes in some clinical trials, patients are followed up more rigorously, and we all know that patients treated in clinical trials compared to normal patients, their outcomes are generally better. So registry data provides a very good snapshot and also provides data in terms of auditing new treatments to make sure that they're safe. Of course, registry has limitations. They're all retrospective. The data were collected by the individual sites from the 15 different hospitals, and it's always subject to some degree of the collector's bias. Sometimes there might be inaccuracies in some of the data collected, but it's additional information. It's quite useful, but you need to bear in mind some of the limitations.
Thank you very, very much. And then on that subject, you probably won't know the answer, so I will, at the very end of the questions, ask if somebody from Combat can answer whether there are any more randomized clinical trials planned and on the way. So we might say that, although that's a good follow-on from that question, because we've just been discussing RCTs, I'm going to continue to direct clinical questions to you if I can, and then open up the floor to somebody from Combat. So, a question here, do you have any experience of using HIVEC for longer than 1 year on patients? I don't know whether that means from a maintenance perspective, or just, a continual perspective.
I have to admit, I don't have any experience, for that. So I think a lot of different centers have different treatment regimes, and because of the lack of standardization, it might be quite difficult to determine what is the best treatment, and it'll be useful in terms of the registry going forward to determine what the outcomes in terms of those with maintenance and those without maintenance, and how long maintenance would be given for.
Perfect. Thank you very, very much.
What we see what we see from around the world mostly is that exactly as you've said, Shen, 6 treatments probably for intermediate risk, and then for patients who are high risk or BCG failure, the further 9 monthly maintenance treatments are indicated. We don't have anybody who treats for longer than a year, though. I think on behalf of our shareholders, we'd be quite happy, but I think the clinical benefit is probably 6 plus 9 for high risk, and that's the maximum.
Okay, thank you, Guy, for contributing there as well. Have we got any experience, or Shen, within the registry, do you know of any experience using drugs other than mitomycin with HIVEC?
So there's some interesting data from Brennan Min's group at Duke, where they're trialing gemcitabine. Gemcitabine is used a lot more in the States compared to the UK. And I believe there's an upcoming trial, which I'm sure you guys will touch upon, looking at gemcitabine in terms of with the hypothermia system.
Fantastic, thank you. And then there's a question come through here, and again, I'm not sure whether Shen will be able to answer this one or not, or again, feel free to pass on. So question is, the reported outcomes data are similar with RITE and HIVEC technology, technology and treatment. Could you give any overview of how the technologies differ and if there are specific advantages, disadvantages to either approach? Again, if you don't feel comfortable answering that, please say so.
Okay, so the hypothermia delivered using the RITE system essentially uses radiofrequency, and they've got some preclinical data suggesting that this results in the formation of nanotubules leading to cell death. So it heats up the lining of the bladder itself, and the chemotherapy that they circulate is actually at room temperature. In the combat system, essentially, you are circulating heated mitomycin itself, and that heat that's being circulated is then conducted to the lining of the bladder itself. The RITE system has been in the market for a lot longer compared to the combat system. There's some preclinical data suggesting that if you use the conductive hypothermia system, such as the combat system, you deliver adequate amount of temperature to the lining of the bladder itself. But I think a lot of these differences might be preclinical, and that's why we are at the phase that we're treating patients with these systems already. So it is the outcomes from randomized trials. These are what we should be comparing them against. Anecdotally, the combat system might be slightly better tolerated because of a slightly smaller catheter. The catheter is slightly less firm. With the RITE system, the catheter is a little bit more firm because you've got the radiofrequency antenna inside. So there's some degree of patient comfort. Yeah.
Brilliant. No, thank you very, very much. So there's a couple more clinical questions. So again, there's only a couple here, and then I'll ask about clinical trials. So if anybody else, clinician-wise, has any other questions you would like to submit, I would ask you to put those in the chat in the next minute or so. So the next question, Shen, thank you everyone as well for engaging with these. If recurrence occurs after HIVEC therapy, might it be useful to start HIVEC induction therapy again?
So I think it depends on when recurrence happens. So if you look at the BCG unresponsive definition, essentially if you treated somebody with HIVEC induction treatment and at your 3 months follow-up you see a recurrence of papillary disease, one might suggest that you have now HIVEC refractory disease, and I believe that you had a trial of an alternative treatment already. And these patients should be counseled in terms of radical cystectomy options. Or you might want to try a different treatment modality if the patient is actually very, very against radical cystectomy. I'm not too certain. I mean, there's limited data on this, but I'm not too certain if you are going to repeat treatment again if you've got recurrence following induction chemotherapy. I mean, to me, it doesn't sound like a very wise treatment option.
Okay, no, thank you very, very much for that. So we will be wrapping up shortly. So one of the last questions, do you have any experience with epirubicin?
Again, in the UK, epirubicin is not used very often, and I don't know any centers that might be using epirubicin. and I believe that you guys will be touching upon the same trial that would incorporate epirubicin.
Perfect. So if there are no other questions from clinicians coming through, and thank you very much everyone for your questions, I'm going to ask if Edward, potentially, if you're there, can tell us a little bit more about the next phase of clinical trials planned on behalf of Combat.
Okay, just before that, I'll talk about other drugs. HIVEC has been used with both gemcitabine and epirubicin. There is one Italian trial which has actually referenced the use of epirubicin, and it's been well tolerated, and there weren't any issues.
I'm just in the process of dropping that one into the chat so everyone can see it, boss.
Thank you.
Fantastic. So, and we know anecdotally that, like I say, it's been used. Obviously not widely like mitomycin. Mitomycin is the most commonly used, but in certain countries, there isn't actually access to mitomycin, and in those cases, like I say, both gemcitabine and epirubicin have been used. Gemcitabine and epirubicin, from a scientific perspective, when you actually look at them, they've got smaller molecules, so actually hypothermically, they may be considered to work better because they'll be absorbed better. And also looking at cell line studies, that they look like they might have actually well performed better hypothermically. With that point in mind, we are about to hopefully embark very shortly. It's just been approved. It's going to be a Spanish trial, which will be looking at both, well, initially it'll be gemcitabine, where we'll compare hot and cold gemcitabine, and we'll also compare hot and cold epirubicin. It'll be a neoadjunctive treatment, so we'll be giving it before surgery so we can actually see it, and we'll also be measuring various markers and also looking at the PK analysis within those patients. The total group of actually 60 patients that will be in that study, 15 patients in each arm, 4 arms in total. And once we finish that study, the best of epirubicin or gemcitabine, and if they both have good results, we'll then go into a further trial where we will actually use it with mitomycin as well. So, and that trial will be a chemoresection trial again, so a neoadjunctive setting, looking at low-grade, intermediate, recurrent patients. So we hope that we'll have both those trials. One will follow the other once we finish that. And following on from the data that Shen's published, because we've got the promising results, we are also planning to run a single-arm study, because there's no comparator at the moment, looking at both CIS and CIS papillary. So there'll be 2 arms within one study, and we hope to be able to start this trial in the second part of 2021. At the moment, it's quite difficult to run trials because of COVID, so everything really is actually on pause in terms of establishing new trials. But we do hope to have the first one running by maybe the end of this year, beginning of next year. And then we plan a BCG unresponsive trial as well, to be able to have level 1 phase 3 clinical evidence from that supports the data that Shen has produced.
Fantastic. Hopefully that was clear in terms of the trials. So there's certainly one earmarked to start very shortly, and the rest following that. Again, COVID causing delays and disruptions to 2020. So thank you very much, everyone, for your questions. If anybody has any other questions, please type it very, very quickly. If not, we're going to thank Shen very, very much for joining us and presenting the slides that would have been presented at this year's EAU, virtual for the first time this year. And thank you very much, everybody else, for joining us this afternoon or this morning, whatever time it is where you are. It's very much appreciated. So just to confirm that we will send a recording out and a post-evaluation feedback will come out pretty much immediately. And as soon as we've edited the recording to ensure that, beginning and end, I will send that out to all the registered participants. So thank you very, very much, everyone. Thank you, Shen. Thank you very much, everyone, for joining us.